Okay, well, thank you very much, and I'm really pleased to be able to come here and talk today. Guess I have control of the slides. What I chose to do today, because not many people that don't work internationally are familiar with us, is give you a little idea of what we do and where we're going with this. Actually, we're not so sure where we're going as of recently, but and where there may be some overlaps and synergies with this institute. So I'll give you Fogarty 101, a little landscape of global health and how it influences how we define our mission, some strategies to address this landscape with a constrained budget, always of interest, and a little bit about our programmatic portfolio and our opportunities for partnership with NACNR. So I just lost, oh, here we are. So for those who have not heard of us before, we are one of the 27 institutes and centers at NIH. We're the smallest one, and we're also the only one that's specifically tasked with working internationally and doing international training and research. We define our mission very broadly as science for global health, which means almost everything in the world that concerns health. And we have some ground rules that are, I think, quite different from the rest of NIH. So I wanted to quickly give you a little perspective on that. Our budget is about $50 million per year for the extramural budget, and that's about 80% of the entire center budget. All our grants are solicited, so we don't participate in the parent FOAs, and we are constantly writing FOAs as a result. All of our funding involves collaborations between U.S. investigators and investigators in lower middle income countries, which is essentially defined by the World Bank as everything that's not high income. And we pivoted from doing all of international about 20 years ago, and now we focus on the non-high income countries. Almost all of our grants, however, go directly to U.S. universities, which then subcontract with partners in other countries. We highly leverage and partner with all the other ICs, including NACNR, and sometimes with other government agencies. And this allows us to expand our mission in ways that make a more systems approach or a more holistic approach to some of the public health problems that we're trying to address. And I think that might also resonate with you. We try to be non-duplicative. If somebody else is going to be funding in the same area, there's no need to use our small dollars there. We try to be cross-cutting because we're not confined by a disease silo. And we like to be integrative, again, with this systems thinking kind of approach. And we hope to be catalytic using our small dollars to leverage into something that's a larger opportunity. The one criteria in all of our application reviews that is missing from the rest of NIH is a focus on capacity building. So even though we lead with science, and the most important thing is the excellence of the science, there is a review criteria that says, is this application, is this work going to build capacity in a partner institution in a lower middle income country? And I'll go back to that capacity issue in a minute, but it's a very important part of our mission. We also recognize that capacity building is a very long process. In many cases, we're starting from a very low baseline, and it's going to take decades, in some cases, to get that institution to be a rigorous, robust, and high-quality research institution. So we're pretty much in it for the long haul. Now, this WHO analysis of the global burden of disease has really influenced the way we allocate our funding. If you look at the 1990 pie, you'll see that about half of the global burden of disease was in communicable diseases, maternal and child health, and nutritional areas. However, the other half, which was largely neglected for decades, were in the non-communicable conditions, including neuropsychiatric disorders and injuries. If you look at funding during this period, almost all of the funding, and the funding really going back 50 years, has been in that communicable disease area. So that when you go to institutions in these countries, even if they're very advanced and mature research institutions, most of the researchers have been trained in infectious diseases and not so much in the non-communicable diseases. However, if you look at the 2020 projection from WHO, you can see that with advances in the treatment and control of infectious diseases and better survival of children and of mothers giving birth, that infectious disease, maternal and child health quadrant has shrunk to about a quarter. And now about 75% of the burden are in these other areas. However, if you look at the funding for this is from 1990 to 2016, my arrow is pointing to a little tan bar. That's the non-communicable diseases. And even if you look on the right and you see percent change over that period, it looks really large for the non-communicable diseases. So we're going from 0 to a little bit. And this has really influenced our strategy. So what is our strategy for being a small center with essentially a huge mission? I'm going to give you 3 sort of philosophical cartoons of how we think about this. The first one is that we don't participate in the unsolicited pool or these parent grants, but yet we know that it's really important that the community tell us what's important. They're on the ground, they're in the situation, and we want them to lead. So we need to have some kind of bins for them to apply for that are essentially unsolicited and investigator-driven. On the other hand, if you look at the lopsided funding and the global burden of disease, we also need to incentivize the community to work in areas that they may not have worked in globally. I mean, certainly we have a huge amount of cardiovascular research here. In some of these countries, there's absolutely 0. In some countries, there's absolutely 0 neuropsychiatric research, and there isn't even any neuropsychiatric care. So we need to incentivize by leading with funding opportunities, just like all ICs do. These are our 18 current programs, and on the left are the less prescriptive programs. We have a global infectious disease training program. Anything in that area you can apply to do training in. A HIV training program, non-communicable diseases, and the Medical Education Partnership, which I'll come back to. We have a number of fellowships, again, in anything NIH works in. And we just started a non-communicable diseases and injury small grants program. And you'll notice where there's red stars, NACNR has been a partner either in the past or in the present with us. On the focus side, there's a long list I won't go through. I just highlighted some. About 10 years ago or 12 years ago, we started a trauma and injury training program to address that big quadrant about injury. On the bottom, there's a brain disorders program. We're partnering with about 8 other ICs in this area to do small grants that then leverage themselves into R01 opportunities from the other ICs. And that's anything in neurological and neuropsychiatric disease. And we recently started an mHealth program, and I believe you also have an mHealth offering. There's a lot of hype about the potential for mobile technologies to improve healthcare in low and middle income countries, particularly where there's no healthcare facilities near most of the population. And we want to explore whether these types of interventions are actually effective. And if you want to ask me about any of the other ones, I did have a biodiversity background, so I've been working, I'm still working in biodiversity, only in the context of drug discovery, and we have some other boutique offerings there. The second cartoon is a house, and we started with this when Jerry Kirsch was the director of our center. The top floors of the house are pretty obvious. If you want to build institutional capacity, you have to train people, so that's obvious. And you have to give them some kind of research opportunities. That's also obvious. What's not really seen, and I put a line that's the ground level, is what's in the basement. In our institutions, we are used to, in the United States, we're used to having a lot of research resources that support researchers. If you want to do a clinical study or a human subject study, there's an IRB, and they have the expertise to give ethical oversight. You have informatics capabilities. You're both informatics literate, and you're also able to develop software that you might need for your research project. You can't do research anymore without that kind of capability. And you have libraries, animal welfare offices, grants management offices, fiscal responsibility, business offices, and so forth. All of that is absent in many of the institutions that we work with. And who is going to build it? So Fogarty has taken that on in addition to the research training, the research support training. And I'll give you just one example of that, which is in the area of bioethics, which actually NIMR was an early partner in this program. We started it as a R25, an educational development program, and we focused on developing culturally relevant curriculum for bioethics master's degrees. This is mostly for human subjects research, but we also touch on the bioethics of clinical care decision-making and bioethics as it impacts national policy. And the trainees have, in many cases, initiated and developed IRBs, and they've become very informed members of it and leaders of it, which not only helps the capacity building for that institution, but all of the U.S. collaborators, particularly from NIH working there, can now take advantage of having an informed and responsible IRB. And then at the request of the community, we recently started a PhD and postdoctoral program for bioethics research. And you can see we've worked all over and have at least 1,000 master's graduates. This actually has a picture. Oh. It's animated. Sorry. Okay. The last cartoon to look at our philosophy, and we've really tweaked this very significantly over the last 10 years, is if you're training somebody, if you just train somebody from a low and middle income country and send them back to their country, it's likely they are going to fail. They have no peer group, they have no support at their institution, they have no other opportunities. There is no tradition of a postdoctoral period, so they immediately are doing teaching, they're doing administration, they are stars, but it's not helping their careers. So we needed to build in the pieces that were missing so that we didn't lose the investment we made of training someone for 5 years in a PhD program and then having them become an administrator and not do any research. Or worse, leave the country altogether. So we've put in some fellowship programs of various kinds for both the U.S. students that are going to be the collaborators in this bilateral relationship, and also for the LMIC scientists. We put in some small exploratory grants that are in protected SEPs or protected reviews so that they actually have a chance to compete for these things. And we've partnered with others to help them make that transition to an R01. Now, other ICs have partnered with us on all of these programs, and they've taken advantage of this strategic pipeline for their own purposes. So if they want to build their own international community, often they direct their T32 trainees into our Global Fellows and Scholars program, which I'll mention in a moment. Or if they're building centers of excellence for research in other countries, they take advantage of this whole pipeline to contribute to building that enterprise. I'll give you only one example from training, and this is our oldest program, our AIDS International Research and Training Program. Again, NINR was an early partner in this. These are U.S. LMIC institutional collaborations, but they're exclusively to train the scientists in the LMIC. And we've trained thousands of scientists at this point. And the output of that, yes, they all had a lot of publications and so forth, is that they've become engaged in some of these very landmark, large intervention trials. And so I just mentioned some of them for the past decade. The prevention of mother-to-child transmissions, the circumcision trials at Rakai, the prevention of treatment for discordant couples, and so forth. If you look on those papers, our former trainees are now the country leads and collaborators on those papers. Also, although I don't like losing people from research, very importantly for these countries, you need somebody in the governments who really understand what evidence-based means and are going to be supportive of research and not just try to increased care. And these are examples of all former trainees in the AIDS program that have gone on to become ministers of health and leads in various government agencies, and that have been extremely supportive of promoting research in their countries. I'll give you one example of a fellowship. I picked the ones that NACNR has participated in so you can see the connections. But the Global Program for Fellows and Scholars is one way that we try to enlarge the research workforce. So you need cardiologists, you need nurse scientists, you need pulmonologists. There's not always an easy way for the U.S. Experts in these fields to get an exposure to global health that might convince them that it is of interest and useful to work abroad. And so these are one-year fellowships that send them to research sites in LMICs, usually NIH-established research sites, to do one-year projects. And then they have a conversion experience. They almost all have this conversion experience and decide that they really want to do this for their career. And then they go on and often apply for our K awards, both the US and the LMIC scientists, and go on to have this as part of their careers. And we've trained about 900 scientists, and we're in our third round now. And you can see they have, this is just from the recent group we sent out a wide variety of areas they work in: improving women's health in Malawi, developing triage tools for children, researching pediatric cardiology in Malawi, and so forth. Almost every area of research. And I just wanted to point out, we also developed the first K at NIH for foreign scientists called the K43, again, because of this lack of a postdoctoral period. And I think Dr. Grady mentioned that we've noticed at NIH that most mature investigators are getting all the money. That's really true in spades in most of these countries. The most senior investigators have all the grants, and the junior investigators don't have much of a chance. So we've put in a postdoctoral period to try to mature this younger layer and to move them up into research leadership. Okay, and finally, I wanted to mention the Medical Education Partnership Initiative. Some of you may have heard of this. This was an initiative that we started in 2010 that was sponsored by PEPFAR and administered by HRSA and by NIH. And the goal was to strengthen the medical education system in Africa. We added an environment that values and nurtures research to increase the quality, quantity, and retention of physicians on the continent. We gave out 13 awards, and if you do any international work in Africa, you'll recognize these names. These are some of the strongest medical research universities in Africa. They have a lot of NIH funding, and they have some very, very talented scientists. They also overlap with H3 Africa and other NIH investments. On the right, you can see the pie chart. So PEPFAR gave us $100 million to do this, but NIH added an additional $30 million, which came from the Common Fund, from the Office of AIDS Research, and from individual ICs. Again, NACNR is highlighted there. And what they did, besides trying to develop their own medical education system, is they reached out to other less mature medical schools in their countries, and they reached out to their US partners to try to strengthen the entire medical system. And they formed a really amazing network that had never existed there before. Many of these schools had never talked to each other and certainly hadn't engaged in common research and activities. We ended up with 34 African institutions and 31 mostly US institutions. And they've done a lot of activities. I won't go through them, but they focused on curricula and educational research, but they also used research as an incentive to retain physicians. And they were increasingly integrating research into their educational practice. And then the linked awards from NIH were specifically for research and research training. The African investigators really felt that this was transformative. They called it a movement. And they formed something called a PI council where they met on a regular basis. These are deans of major medical schools that had never talked to each other. There was no forum for that. And so they began to meet on a regular basis. So this PI council is important foreshadowing because I'm going to tell you where we're going with this in a minute. We also asked them at the end of this 5-year period, where I think it was quite visible to everyone that there had been a real transformation in how these schools were educating their physicians and retaining them. What was missing? And they went back to the junior faculty, these faculty that had gotten PhDs and were never given any release time to do research and were never given any further mentoring time like we would in a postdoc. And we developed, again, a first for NIH, a institutional career development program through the Common Fund that all of the ICs are participating in to both do research mentoring and to build that infrastructure in the basement that I showed you before. Now, at the same time that we're doing MEPI, you might be aware of NEPI. So that's the Nursing Education Partnership Initiative that was done in parallel to MEPI. NIH was not involved with that. HRSA was managing it. And it was mostly for pre-service training for nurses, again, with the idea of addressing shortfalls in the number, quality, and capacity of nurses and midwives. It mostly focused on curriculum and skills development, and there was no research component, which we actually feel was a missed opportunity. It was administered through a coordinating center at Columbia, ICAP, and involved 22 nursing schools and about 23,000 nurses. PEPFAR is not able to continue this initiative. And so when we were having discussions with them what the next phase of MEPI would look like, NEPI became part of the conversation. So here's what the first and second generation look like and where we're headed with this. So in the first generation, NEPI was really quite separate than MEPI. They were not at the same schools, with one exception. They did not talk to each other, and they were not part of the PI Council or this network that MEPI had formed. And then there's the MEPI Linked Awards from the Common Fund, and then second generation Common Fund Junior Faculty Awards. What we're proposing now, and PEPFAR administrator, before the new administration came in, had agreed to this, and we have an MOU. We'll see what happens with this new administration. Are 2 new programs. Both of the programs are based on the idea of an increased amount of interprofessional education and networking. The programmatic awards on the far left would be somewhat like the MEPI Awards, but where appropriate, and it's not always going to be feasible because the schools are so separate, they would incorporate more interprofessional education and incorporate a research component as a more integral part of medical education. And the middle thing grew out of the PI Council, and they're proposing an interprofessional educational network. And the PIs did not hesitate to move forward on this after our consultations and discussions on this. So at the 2016 annual symposium, both the NEPI and the MEPI PIs came together, designed the whole symposium, invited their networks to come, and we had a really, I thought, very interesting, very lively, and very well thought out symposium where this is the first time these 2 groups were actually interacting in a formal way. They jointly launched something called AfriHealth, the African Forum for Research in Education and Health. And as Peter Donker, who is the chair right now, said, they're hoping AfriHealth will take the lead in driving solutions to African health challenges from an African perspective. So I would actually appreciate consulting with you guys on how this might work, how fusing these 2 strains might actually be synergistic and good. So I just want to finish up with some final thoughts. Peter Kilmark's our deputy director, and Alicia Levinsky from the NIH Library did a quick analysis of where NIH collaboration, where NIH affiliations are. So they looked at all the papers that acknowledged NIH funding in 2014. And there was 84,478 articles. What was really surprising to me is that 37% of those articles cited at least one foreign affiliation. Is that surprising to you? I found it extremely surprising. When you look at where the affiliations were, the blue bars on the left are developed countries, so you would sort of expect that. But there's a significant contribution from the lower middle income countries as well, which are the yellow bars. And I was wondering why this was. And then I was reading Technology Review from MIT. And there was a column from the president, Raphael Reif, and he was promoting the international or globalization of his university. And these statistics also blew me away. So at MIT, 40% of the faculty came from elsewhere. They're international. 40% of the graduate students came from elsewhere. They're not US. And more than 10% of the undergraduates. And they represent 134 countries. And when I looked at those statistics, I'm sure they're not very different in other universities, it suddenly began to make sense to me what was going on. I didn't tell you about it, but we've had a program for many years called the Framework Programs, where we tried to bring together different schools around global health. And there was, they would decide, well, let's do Introduction to Global Health, and they would, have a small room and a small registration, and 700 students would show up. I mean, and that happened at university after university. We did 33 of these in US campuses. It became the most popular track in the medical school for medical residents. It just exploded at every level. And when I look at these kind of statistics, it makes sense to me that the faculty or the research faculty are reaching back to their friends or their colleagues from their original country, or they're paying back. They moved to this country, but they feel they need to pay back to their country. And the students are already global. So globalization has already happened on our campus. It's not even a question. And NIH is supporting that research. I just found it interesting. So I'm going to stop there, and I'll be happy to answer any questions. Thank you.